So I'm going to be talking actually about the optimizing pH treatment, and my subtitle actually is a very important one, is upfront combination therapy and early intensification, which is a life-saving strategy in PAH patients. So this was shown very nicely by Professor Majdi. The main reason we are addressing pulmonary hypertension so aggressively and so importantly is that these symptoms often lead to delayed diagnosis, and delayed diagnosis obviously by definition leads to delayed treatment. So our main message is really to suspect this in the high-risk patients, suspect it in patients with dyspnea, especially if they're young, detect it and refer as early as possible. And the common constellation is dyspnea, fatigue, and dizziness. Now there's other late symptoms such as chest pain, ascites, and edema, which are heart failure symptoms. And of course, some of these patients have odd symptoms like cough, syncope, and arrhythmias. The problem is that if you have PH, it leads to right ventricular failure and death. And as Professor Majdi showed us, survival without diagnosis and immediate treatment is 3 years in idiopathic PH patients and worse in scleroderma patients as well. So if you permit me, this is basically our first 1-year data at the first start of the center in 2014 with our dear friend, Professor Muhammad Badr. Since 2019, we've compiled our data. We have almost 339 patients now, follow-ups in pulmonary hypertension. And I'm very important to show this slide. This is our 1 year at Cleveland Clinic survival data. And you'll see here something really bad. Those patients who were referred to us for initial late diagnosis, referred from a hospital, sent from a transfer, their mortality within 1 year was 25% higher than those patients who are seen in the clinic or followed up longitudinally. So newly diagnosed patients did poorly because they were poorly diagnosed, misdiagnosed, not treated for a long time. And by the time to come to us, their survival is naturally worse. So why we showed the risk stratification table, and this is something unusual in medicine, we don't usually do that in heart failure or coronary artery disease. We do risk stratification continuously in pulmonary hypertension because it's a progressive lethal disease. Why do we do it? Because it is to avoid worsening RV function. RV function equals death. So describing the patient as stable is not correct. The patients limit their activity to avoid symptoms, even though the RV function is getting worse. If you have timely interventions, therapeutic interventions early, the progression of PH can be altered, progression of PH can be arrested, and without assessment, appropriate treatment decisions are delayed, and unnecessarily delayed means worsening RV function and death. So we definitely integrate the risk table into our monthly and daily and weekly practice. And we do these tests every single time the patient comes to the clinic. We always check for signs of heart failure. If they're absent, the patient is low risk. But please bear in mind, the low risk patient is less than 5% 1 year mortality. So unlike other diseases, we have a high risk at 10 or 20% per year. So this is a very lethal progressive disease. You have to depend on 6-minute walk. You must do NT-proBNP. You have to do frequent imaging. A right atrial dilatation, persistent pericardial effusion is a very bad prognostic sign. And of course, we use the hemodynamics in the initial diagnosis and also in follow-up. So RV function, exercise capacity, clinical evaluation, not just relying on the patient's absence of symptoms. It's very dangerous if you do that. So these parameters have to be tested. And in reality, all the parameters must be in green to be assured of reduced mortality. So here's a patient who has a 6-minute walk of 440, not a lot of symptoms. Fine. Is this patient a high-risk patient? Well, let's take a look. The patient also has occasional syncope. This is a high intermediate risk marker. The patient does not have a pericardial effusion. It's a low risk marker. Now the patient hemodynamics at the beginning were having a low cardiac index and a high right atrial pressure. The BNP was elevated 1,400. So in reality, this is a high risk patient. And what are you going to do? You have 2 intermediate, 1 high risk feature. If you add them all together, the patient is overall not in the green zone. So what are you going to do? You're going to escalate therapy again, rapidly escalate and reassess in a month. And actually, you maintain the low risk by adding medical therapy. I hope that's clear to everyone. If you are low risk to begin with, and you're not giving enough therapy, you're going to progress. On the other hand, those patients who are intermediate or high risk and at follow-up were able to improve their risk stratification had a much better survival than patients who remained intermediate or high risk. And that's really a key point. And if the Swedish registry is any kind of guide for us, if you obtain a low risk status within a year, your prognosis is excellent in spite of maybe having higher risk at baseline. Those patients who improved from stable to low risk, from improved to low risk in blue and green, had an almost 50% better survival than those who remained intermediate or those who worsened to intermediate or high risk. So the mortality difference is enormous. And the way you do it is to actually upgrade their medical therapy. Now, I think one of the key points from the guidelines is maintenance of a low risk profile is the only adequate treatment response, and you have to do the reassessments every 3 to 6 months. If you are intermediate, this is actually inadequate, and you have to increase your therapies as soon as possible. The French registries actually showed this. The French registries use some low risk criteria: low functional class, that's symptoms, good cardiac index, hemodynamics, low right atrial pressure, and a good 6-minute walk. Those patients achieving 3 to 4 low risk criteria had an excellent prognosis, 100% almost survival within 5 years. And how do you do that? By escalating dual and triple therapy, and that is a treatment goal in and of itself. So you want to move to the low risk and maximize the number of low risk criteria. So this same strategy was followed in one of the randomized clinical studies called Griffin. So for those of you who are not aware of this study, this was a study where selexipag, which is an IP receptor agonist working on the prostanoid pathway, was added to patients who already were on endothelin antagonist or sildenafil or PDE5. And these are prevalent patients who have previously been diagnosed. Compared to placebo, those patients who were able to achieve, with the addition of the third agent, 2 and 3 low risk criteria, the majority of the criteria being low risk, had a significantly better survival than those in the placebo arm, and clearly better survival than the patients who only got 1 low risk criteria. So it's really prognostic for outcome, and you really have to work hard to make these patients better. In the post hoc analysis from Griffin, the majority of patients who got the active treatment arm compared to placebo were much more likely to increase the number of low risk criteria very quickly by week 26, by almost a 69% improvement. Now, you therefore have to depend not on symptoms, but also on doing these regular risk assessments, which Professor Magdi showed. And then you also, if you detect lack of improvement, that is intermediate risk, or certainly deterioration, you have to add third-line agent. Now, the other important point that has changed in the guidelines since 2019 is that once you do the vasoreactivity testing, and as Professor Majdi mentioned, only the minority of patients are vasoreactive. If they're non-vasoreactive, the need for initial oral combination is a must. There is almost no role for initial monotherapy. In fact, I put a red X on it because in reality, this is a decision that should be taken only in the Center of Excellence. And unfortunately, we have a high mortality in patients who are coming to our center only on low-dose Viagra monotherapy. It's a mistake, and it leads to really mortality and morbidity. Then, if you're on initial dual therapy with endothelin antagonist and high-dose PDE5, reassess in 3 months. If they are low risk, keep following them. If they're intermediate, it's not enough. Intermediate means I have not improved into the green zone, therefore I will add a third therapy. And if they go to high risk at any point, you have to give them combination with intravenous prostacyclin analogs, which is a complicated process that we do at the Center of Excellence. So the important point is low risk at diagnosis and low risk creation of low risk at follow-up is significantly improved long-term survival. Maintaining a low risk is the essential goal of therapy. You can't just guess based on the symptoms. Patients will not tell you they have symptoms because they're trying to avoid shortness of breath. Regular risk assessment is critical to increase therapy. And finally, don't give sildenafil monotherapy in 2022. It's not right. You really should not be doing that. So the role of combination therapy has been established from the pathophysiology. As Professor Majdi showed you, there are 3 pathways. There is an endothelin pathway because of the destruction and loss of endothelium. So there's overactivation of the endothelin vasoconstrictor. So you need an endothelin receptor blocker. Nitric oxide is reduced, so you need to donate back or give back nitric oxide either through SGC or PDE5. Also, the prostacyclin pathway is significantly downregulated, and you have to give prostacyclin in order to give more vasodilatation. Now, that's the pathophysiology, but what about the combination studies? So the combination studies have become the standard of care since, I think, the early 2006. And most of these studies have looked at initial combination or rapid sequential combination. So within a few months, you're adding the second agent. Now, with that being said, the studies have changed from studies that only looked at 6-minute walk or hemodynamics to long-term outcome studies, the largest of which has been Griffin with almost 1,500 patients, lasting for over 3 years and showing mortality and morbidity outcome. So we have gone from monotherapy in the 1990s to early quick combination to initial combination to also risk-oriented therapy. Remember, again, a low-risk patient is the objective. So using initial monotherapy is really, really frowned upon in the guidelines and should be limited to the center of excellence through very, very specific decision points. Initial combination, reassess, not at low risk, intermediate, i.e. not getting better, just stable, add the third line agent. So when do you give monotherapy? I would say that it is not recommended for the majority of PH patients. It's really for a very selected minority, which Professor Majdi mentioned, are qualified as IPH patients who are responders to acute vasoactivity based on a very strict definition with near normalization of symptoms and hemodynamics. And those patients we treat with what? With high dose calcium channel blockers. And in our large registry, we only have 2 patients like that. Also, we use monotherapy in very frail old patients or people that we are afraid of pulmonary veno-occlusive disease. And that decision is taken very carefully by both of myself and my colleagues in the Pulmonary Hypertension Center. And we follow these patients to make sure that they don't drop off the cliff. So really, it's a minority of patients. Why am I making such a strong statement? Because of these 2 very important studies. The Ambition study looked at patients who are newly diagnosed, initial therapy with either tadalafil and ambrisentan, or either monotherapy with ambrisentan or tadalafil. So either one treatment or both. A 50% difference in mortality and morbidity in patients newly diagnosed, and the curves separate literally between 28 and 48 weeks. So it is dangerous now to give monotherapy. In the Seraphin study, most of the patients were already on PDE5 and macitentan was added in the study, or the reverse, 38% reduction after combination with therapy. So in a disease that's lethal, delaying therapy is dangerous, monotherapy is dangerous as well. You have to use both pathways in order to work this. The Optima study is a more recent study. It's a phase 4 study from 2017 that looked at patients newly diagnosed with pulmonary hypertension. These were given combination therapy with macitentan and tadalafil. The majority of patients by week 16 had improved their functional class at least 1, if not 2, and their pulmonary vascular resistance, the hemodynamics, was significantly reduced by almost 50%. So attacking the physiology. Now, what about triple combination therapy? So triple combination therapy is the addition of a prostanoid or prostaglandin analog. So IP receptor agonist, this is selexipag, it's an oral prostaglandin pathway, added to endothelin antagonist, added to PDE5, triple combination therapy, and additional 37% reduction of cardiovascular events and progression. Now, was this a characteristic of early stage patients, really early mild patients, or late patients? Actually, both. In the early stage patients, functional class to milder symptoms, earlier symptoms, 63% reduction because you're preventing remodeling of the RV, and the progression was significantly better. On the other hand, the more advanced symptoms also benefited. The functional class 3 patients had a 26% reduction. So adding the third line agent is valuable early, even when the patients don't have a lot of symptoms. I hope that makes sense, because this is a progressive disease. So do not limit the addition of therapies until the patient has progressed. Actually, proactively cut off the progression. Don't wait until the patient progresses, because that is really too late. And if you look at this very carefully, this is a very important study that looked at remodeling. Even though these patients had a stable 6-minute walk, these are the green and these are the white patients. If you look backwards, those patients who are in the white curve, they had less symptoms, they didn't have a decrease in 6-minute walk, the right ventricle was getting progressively bigger, end diastolic volume, right ventricular ejection fraction was getting smaller. So obviously, even patients with less symptoms and maintained walk distance, the RV is getting worse. And that's why you have to try and escalate therapy based on things other than symptoms and progression of disease. Now, long-term trials are the Ambition, Seraphin, and Griffin, showed that upfront combination or rapid sequential combination is very valuable. Upfront combination in newly incident patients in the Ambition study resulted, as I said, in a 50% reduction. This is the combination group. This is monotherapy. This is tadalafil on its own. This is ambrisentan on its own. By adding both together, you are 50% better survival. So upfront and sequential combination therapies are not only safe and well tolerated, and also are achieving the goal faster. So initial monotherapy is really for the minority of patients and should not be done for the vast majority of patients. Now, if you take a low-risk patient and you give them combination therapy, look at what happens here compared to monotherapy. This is, again, a very important concept. A low-risk patient, less symptoms, provisionally in the green, you give them monotherapy, their survival is decreased by 25%. If you give them combination therapy, even at the early stage, even low risk, 100% morbidity and mortality reduction. Why? Because by the time the patient comes to you, the right ventricle is already remodeled and dilated. And when the RV fails, it's death. So our ultimate goal is no functional impairment, prolongation of life. How do you do that? By regular early intervention, regular risk assessment, rapid intensification of therapy. Late intervention means it's too late. So you have to escalate in the first few months of therapy and give them the dual or triple combination therapy as the appropriateness is. Now we know from very detailed hemodynamic and echo studies and remodeling RV, remodeling studies with MRI, is that if you take patients with monotherapy in green versus triple therapy in blue, there is a significant reduction not only of the pulmonary vascular resistance, percentage-wise, but also with the right ventricular dilatation. So you can remodel the ventricle if you treat the patients early. And the initial triple combination in severe pulmonary hypertension is very effective by improving functional class, improving 6-minute walk. And this is really regardless of the study. This is a very old study from 2014 that used triple therapy with epoprostenol, bosentan, and sildenafil. 100% of these patients survived and had a very excellent functional class. And in reality, look at the actual remodeling of the ventricle here. Look at what happens. This is a massive chamber, and the patient's being placed on intravenous treprostinil and also oral therapies. Look at the ventricle. It's shrunk. It's remodeled, and the pulmonary hypertension is significantly better. So earlier initiation of combination therapy from the time of diagnosis improves outcomes. On the left here, you have patients who were diagnosed to less than 6 months and treated less than 6 months with triple therapy, compared to those patients who were diagnosed and treated greater than 6 months. The overall survival is significantly different. Here, 30%, here, 50%. It's a tremendous difference. And even the early stage patients especially benefit even more, but the late patient also benefit as well. So it's really just to conclude, the PH can progress rapidly in untreated or insufficiently treated. Being accepting just intermediate risk is not enough. Double triple combination therapy is robust and evidence-based and recommended in all patients. Initial combination with ERA and PDE5 is the treatment of choice and essential. Treatment escalation if the therapy does not result in low risk, i.e. don't depend on symptoms, all of the other parameters are important. Intermediate status, i.e. just stable and not getting worse, is inadequate due to a risk of progression and significant increase in mortality. And I'm just going to show you these very quickly. If you look at most patients being treated in the current era, monotherapy is disappearing, which is great. But there's a lot of patients who remain at intermediate risk with dual combination therapy. And some of them preventively go to high risk. So how do we make that change? We use combination therapy even when the patient is low risk. We add combination therapy with triple when the patient is not maintaining a low risk status. Just to give you a couple of words on selective ag, it's a very novel agent. It's an oral prostacyclin analog agonist, IP receptor agonist, high affinity. It is the only oral one with outcomes. And it was studied in Griffin as well as real world data. There's almost 10,000 patients in the real world data as of 3 years ago. The intensification really is for patients with intermediate risk. It's not intended for high risk patients. And what we have seen here is that with this group of patients, and I won't give you the details of the study, is that in all the functional classes, in patients already on background therapy with whatever etiology, there was a 40% reduction of the mortality morbidity endpoint with congenital heart disease, connective tissue disease, whatever the group, a 37% risk reduction if you were on triple combination therapy, and very effective in the early functional class. The long-term extension showed a 75% 5-year survival in patients initiated on the therapy and staying on it. And also, this is the SPHERE registry, which is extremely useful. It's a real-world study from the US, as I mentioned, on more than 10,000 patients. 63% of patients improved, 15% progressed, and 85% were maintained on their status as well. So I think this is a really important point, and we have to remember that prostanoids are the most underutilized group of therapies in pulmonary hypertension. There are side effects, headache, diarrhea, nausea, and vomiting. However, they are much less intense if you titrate these medications. You have a dedicated nurse or pharmacist that helps you and manage the patient through the side effects, because again, this is a life-saving therapy in a life-threatening disease. So just to wrap up, PH is a progressive disease with poor outcomes. We really need to attain a low-risk profile as the ultimate treatment goal, and keeping the low-risk profile. Addition of selexipag is recommended if the patient is intermediate, not high risk, and certainly if they're not becoming low risk quickly. 85% of patients on top of dual therapy improved or maintained their status with selexipag, and initiating this therapy, 76% survival at 5 years, broad range of patients, and a manageable safety profile that we do in the Center of Excellence with a lot of resources. And thank you very much. We'll take back for some questions and then for Professor Mohammed Huqani's talk. So there is a question from Dr. Rania. What are the complications of monotherapy with sildenafil? So monotherapy with sildenafil, as you saw from the Ambition study and the Seraphim add-on study, actually results in progressive worsening. This is a disease that requires 3 different treatments. If you only give one, the patient will ultimately progress much faster. And I think that's one of the key points that you have to bear in mind. So giving monotherapy in heart failure is no longer accepted, right? We always have to give ARNI, which is valsartan and sacubitril. You have to give a beta blocker. You have to give an MRA, and now you have to add SGLT2 inhibitor. So you cannot use substandard therapy. It will lead the patients to progress. Question real quick about SGLT2 inhibitors. No role in PH. They haven't been studied, but in patients with heart failure and preserved ejection fraction, what we call group 2 pulmonary hypertension, certainly the use of SGLT2 inhibitors along with heart failure therapies is useful, because you're treating the left ventricular dysfunction, the diastolic dysfunction, and the heart failure. And there's a question from Dr. Muhammad Rahim about when is atrial septostomy used. So atrial septostomy is a very interesting technique. It was actually published in a large series in Mexico, high altitude. It seems to work in that population. It's not clear why. It's a palliative procedure. Once you reach that stage, it may be too late, and you have to make sure that the patient will become more hypoxic because you're creating a shunt, and you may actually lower the pulmonary artery pressures, but not tremendously. So I think we have to be very careful about this strategy. We have access to medications, and we should